Hello and welcome to the My Dietitian Journey Podcast. My name is Adam. With me is, of course, Felicia, the dietitian extraordinaire. We're going to get into some stuff today. Check her out on the socials. We're going to talk about billing today.
Yes.
Billing insurance companies, the bane of many private practices' existence, not just with dietetics. They're quite the beast to work with sometimes. So we're going to get into the ins and outs of billing insurance and things you should know. So should we just jump right into it?
Yes.
All right. If someone's new to private practice, just want to get into a little bit about becoming an in-network provider.
Yeah. So first you're going to need to get your EIN, so your tax identification number, your NPI, liability insurance, and then state licensure if required.
EIN, employment identification number,
yes,
is what it stands for?
Yeah, the federal number. So you're going to need that first, and then you're going to fill out what's called a CAQH ProView online application, which is basically a credentialing database, and you get an ID number, your provider ID, which you would then use for every insurance company when you apply to work with them. So most insurances have a link on their website that says join our network or become a provider. And the easiest thing is to search for an insurance company and be a provider or become a provider to find that page. And then the next step would be credentialing, where you share your information. They verify things like your education, your training, and then would be contracting, where they actually send you a contract to be an in-network provider. Usually it's like 30 pages long, and some of it doesn't actually apply to dietetics, but you still want to make sure you review through it and make sure that you understand what things you have to do as a provider in-network. And so that's the brief.
The general timeline for becoming a provider. About how long does the process take from start to finish if you had to estimate?
So anywhere from 30 to 90 days. And it's such a big range because it depends on the insurance company, the time of year too. So when I first did applications to become an in-network provider, it was like 2015. And there were some insurances that it took 60 days. And then some insurances that the 60-day mark, I still hadn't heard from them. And I had to call and figure out where I was in the contracting phase. So I did have one insurance that did take 90 days for the entire process to go through. And that's without having maybe any errors too. So if there's any issues, that could also delay the process.
So if you're, there is a particular insurance company that took forever to get back to you that just now got back to you. How long did that take?
So
I don't know if we can say the insurance companies. Does that matter?
I don't think so.
Yeah, it was Aetna.
Aetna. So, and I'm in Pennsylvania. So I actually applied to be in network with them probably 3 years ago. And I kept getting letters of denial saying that the network was closed, which is something that can happen. But they will often say that they have too many providers in your zip code or in your area. You can appeal the letter, or you can contact them every so many days to see if the network is open. So I kept doing that and submitting more applications to see if I can get back in network. And I stopped after about a year of doing that. And then about a year ago, I was getting more calls from people asking about if I was a provider, and obviously I wasn't. So
people were calling you and asking if you were a provider for Aetna.
Yes.
Okay.
Yeah. So they were finding that either the dietitians that were listed on there had no appointments available, they weren't taking new clients, or their appointments were like 2 months out. And so that was, they ended up just Googling my name or Googling a dietitian, and my name showed up as one of the ones on that list. So I reapplied again to Aetna, and just recently. So I applied, it was like the end of January, and at a certain point I was like, okay, I guess they're not going to contact me, but it said like up to 60 days before you would receive any information from them. And it was just this past week that I actually got a contract emailed to me.
So kind of still in that time frame of 30 to 90 days, but just the battle of getting in with certain companies, certain insurance companies, that's what it can be like.
Yeah.
Don't give up if you really want to be a provider for a certain network or a certain provider or insurance company. Just, be persistent. There are avenues to take with that.
Yeah, and start early. Like I didn't realize how long it was going to take me to actually become a network. And so if you are thinking about becoming a provider, just start the process early. So then that way you're not in the waiting game of having a client and then having to wait for the insurance company. So that is one thing I'd suggest. And the other thing is keep a log of when you actually submit applications and if there's any contact numbers on there as to who to contact. Because if you're applying to a bunch of different insurance companies, it can get to be pretty overwhelming as to like, when did you apply for this one and who do you contact to follow up with? And emails and phone numbers are both good to do that. So
a list,
yes.
An Excel spreadsheet, good to stay organized. You should probably do a podcast or like some videos on that. Mm-hmm. So how often do you actually bill for your appointments once they're said and done and you're in with your insurance companies, you need to bill for these appointments? How often do you do it?
So I like to bill every day. So usually I bill for services the same day that they're rendered. And depending on my client load for that day, I might bill right after I see a client, or I might bill at the end of the day for like a bunch of clients all in one if I'm using like the same system. Now, when I first started my practice, I kind of like billing for me now is a lot easier and it doesn't take me that long. So I can easily bill between sessions. But when I first started, I kind of really didn't know what I was doing. And so I would often wait until the end of the week to then bill for the insurances because it was just overwhelming.
So you used to batch your billing. You used to do it all in one shot.
Yes.
So can I just ask, because we're talking about billing like everyone just knows what that means, or like what you're actually doing. You have a client. You use a particular platform. Can we say brand names?
Yeah.
All right. So I do a little bit. Simple Practice is what you use. And you have your appointment and you bill through Simple Practice as well.
Yes.
What does that process actually entail?
So if I'm billing directly through my EMR, which is Simple Practice, there's a spot for billing.
You're billing through your EMR?
Yes.
Yeah. So that's Simple Practice is also the EMR. It's a bunch of things.
Yeah. And there's a bunch out there. That's the one that I use. And so when I'm billing through it, it actually generates the claim after. So it doesn't submit it on your behalf, but it generates after the service has been rendered. So it shows up as green that the appointment was held. And I can click and just literally look through and see if I need to change any of the information. Like if the time frame was different, I need to change how many units I billed for, which we're going to talk about, units and all of that today. But I change any of that information and then I can just hit submit, but it populates the patient information already. So all I have to do is just make sure that the diagnoses are correct on there, the time frame is correct, and then the amount that I'm billing for is also correct, and then submit it.
Do other platforms auto-generate claims for you?
So it depends on the platform, and I'd use a couple of platforms. So I get a charge per claim with Simple Practice. So I use them for some insurances, but not all. I use the Pair Portal, which is associated with like Independence Blue Cross, and Amera Health, I believe, is also linked under there. And for them, you search for the patient's subscriber ID. So you put in their member ID, and then if they're obviously a member, their information would populate, and then you can click to create a claim. And it's more of like a step-by-step page process than it is a blank CMS 1500 form, which is nice because you could just kind of fill in the information and then it populates everything for you on this claim to electronically submit.
So that's through the actual insurance company's website?
Yeah.
That you go there to file it?
So it's their, it's not their website. I mean, they use the Pair Portal, it integrates with them, and that's what they recommend. Highmark uses Navinet. I know Aetna uses like Ability. So there's all these platforms for each insurance company that they like you to use, or you can use your EMR.
Okay. So just to recap that, you have a session with a client. If you're using an all-in-one platform, sometimes it'll just auto-generate a claim for you, and you do a few things within the platform, and then it submits the claim.
Yes.
Otherwise, you use this Pair Portal, which step-by-step takes you through the process to generate the claim that you would then select the insurance companies to submit it to.
Yeah. So you would be like in the specific insurance company like section of it. So like the Pair Portal is only for certain insurance companies, or like Novita Sphere is Medicare. So like it's only for Medicare claims. And so it's their specific portal that they would use for that specific plan. Or insurance company, I would say. Or yes, then you would, other than that, you would use your EMR, which then you can be submitting to many different insurance companies on there.
So the advantage of having an all-in-one platform like an EMR is that you're paying for it and you're paying per claim, but it streamlines the process for you. If you're not doing that, which you don't have to, it's an expense if you don't want to do it, but then you have to go through the process of using the specific portal for certain insurance companies. Like you said, Novitasphere is
for Medicare
specifically. There was another one you mentioned.
Availity is what it's called, and that is Aetna. And then Pair Portal is Independence, and Highmark uses Navinet.
Navinet, that's the one I've heard of.
All different ones. And what's nice too about those ones is that they're free. And while you're in that contracting phase and even in the provider information sections of the websites, they would tell you which platforms that they either recommend or require you to use. Like United Healthcare has their own one too. And so everybody has their own portal. And usually they're not something that's like a paid, subscription to have to use. But in using those platforms, you can also then verify benefits and also check that someone has an active plan, that their information is correct. So you can use those platforms to not only submit claims, but also, is this member actually active with a policy? And then seeing also if your claim was accepted and rejected. So there are some benefits to using those as well.
All right. So just quick how you bill. That's how you do it. And then so how often you bill immediately after services are rendered, partially because you have the convenience of an EMR that you're using as a sort of an all-in-one. Not endorsing it necessarily. It has its issues. Yes. Recently, we don't have to get into it. But okay. So what does someone new to billing need to know? I guess we kind of just covered that.
A little bit.
Is there anything else specific that, hurdles, unexpected curveballs that you sometimes face with claims? Do you want to talk about when they get rejected sometimes and what to do?
Yeah, so I think we are going to talk about that. But if they get rejected, there are a few things that you can do with a claim getting rejected. One, sometimes it's a matter of having an incorrect CPT code or incorrect ICD-10 code or something that's not directly related to the member's policy, which
we're going to get into that stuff if you don't know what that is.
Yeah, we're going to touch on those. But if it is rejected, it would say on there like the reason for rejection, and usually it's like a code and then like a sentence. And so sometimes it'll say like not deemed as medically necessary or beyond limits or something like that. It would say it under there, so you could see like why it was rejected. Or like I've gotten ones back when I was first billing where like the NPI was incorrect or something was not, in the insurance database. So I was using something incorrectly.
Wait, your NPI was incorrect?
Yeah, it was when I was switching from using the individual NPI to the group NPI. And in doing that, some of the insurances were not updated just yet. So there was getting like a denial that this person's not in network, when in reality I was just kind of jumping it a little bit too soon without realizing that what hadn't really caught up just yet. So, but yeah, so that would be the other thing. And keeping track of everything. So when you submit a claim, you can check the database and see if the claim was accepted or rejected or whatever. But being able to keep track of when you submit a claim and to what platform, especially if you're using multiple platforms, that's a good kind of like housekeeping thing for the business, because it can get to be pretty overwhelming to, when did I submit this claim? And to make sure that you're getting paid, because typically payment is anywhere from like 30 to 60 days if you're waiting on a check or if you're getting like electronic funds transferred. And if you haven't gotten something by then, it probably got rejected. And so being able to have like a spreadsheet or some kind of sheet to, keep track of when you submitted claims and when you submitted claims and where, can be really helpful just to stay on task.
Now's probably a good time to talk about CPT and ICD-10 codes and what they are.
Yes.
Before we get into the specifics of like how to modify them and things. Because those are codes that you'll need to have your claims accepted. Do you want to just briefly get on that? Or
yeah, so a CPT or current procedural terminology codes would be those that basically describe the service or the procedure that would be provided. So this would be either from a physician, from a dietitian, any healthcare provider. So that would be the CPT code. Now, there are 3 common ones that you'll see in dietetics for medical nutrition therapy. So 97802, which is considered the initial session. So it's billed in 15-minute increments for an individual. And then 97803 is the follow-up face-to-face with an individual, again, 15 minutes. And then there's 97804, which is technically a group, but it's for 2 or more people. And that's billed in 30-minute increments. So if you have a session that is an hour, it would be considered 2 units because it's 30-minute intervals.
So when you use a CPT code, so like say it's 97803, it's a follow-up, it went for 45 minutes. Do you have to list the code 3 times, or do you have to put somewhere that it's 3 units?
Yeah, so you would have the CPT code just as its own, because that would define the service. And then you'd be looking at the units. So like I mentioned, the 15-minute unit. So if it's 45 minutes, that's technically 3 units. So with some insurance platforms, you can specify units or minutes, but by default, usually it's set to units. So again, 1 unit would be, again, if it's 97802, 15 minutes. So if it's 45 minutes, then it would be 3 units.
So that's CPT. That's the procedure itself. ICD is something else. You want to talk about ICD codes?
Yeah, and one thing I want to mention just with CPT codes, that certain CPT codes are only billable by certain providers. So just keep that in mind, is that you might see lots of different CPT codes if you look them up, and not all of them are ones that can be provided by a dietitian. So
well, you can really only do 97802, 3, and 4.
Yeah, there's also G codes, which are for like additional visits. Like for Medicare, there's G codes that are associated. I don't remember them off the top of my head, but I think it's G0270.
I don't think we should get into that. It's you're only getting 99% of the time it's 97802, 3, or 4.
Yes. Yeah.
All right, ICD, what are we talking about here?
So these are basically the healthcare diagnoses and procedures. So this is defining like an individual's diagnosis or their medical condition, which...
ICD.
Yes.
Did we talk about International Classification of Disease?
That's what it stands for.
Yeah,
yes.
So the disease. So one is CPT is procedure, ICD is disease.
Yes.
That's the easy way to remember it.
That's a simpler way. So with an ICD-10 code, not all of them are ones that you can just use. You have to have a referral on file or some kind of physician documentation, because we can't make a diagnosis as dietitians unless you have some kind of, credential or you are a physician and are able to do that. So there's Z codes like Z713 and Z713, and that one is dietary counseling and surveillance. That's like the code I use pretty much all the time. It doesn't require a physician referral. There's also Bmi codes, which the Bmi is just a mathematical equation. So that's something you can calculate. But something like obesity, which is an E code, that one you need a physician referral for because it's a diagnosis, or diabetes, or some kind of cardiovascular disease. And there's thousands and thousands of ICD-10 codes. So many of them do require a physician referral or some kind of documentation, because you can't make a diagnosis as a dietitian.
Can I just give a brief overview of what these codes actually are?
Yes.
CPT Procedural Codes, there's a giant book of them, and they exist for literally every type of procedure you could possibly imagine. They're 5-digit codes, and the ones that you guys would use as dietitians are like a tiny sliver. Every single procedure you can think of has a code. ICD is for literally every, not just disease, but everything that can happen to you has an ICD code. If you fall off a horse and break your leg, there's a code that is specific to falling off a horse and breaking your leg. Not breaking your arm, breaking your leg. Breaking your arm would be a different code. That's how specific these codes are. It's ridiculous. And you guys have certain codes that are specifically applicable, but it's literally for every disease state, which includes injuries too. That's what these codes are. There's giant books you guys can buy, but it's a complete waste. There's an ICD-10 database online that's very accurate. You can usually Google CPT codes too. All this stuff is available online, but if you want to be a nerd and buy the giant books that they come in, go for it. And then you can flip through and look at all the codes yourself. It's ridiculous, but that's what they are. They're codes that exist, and every letter of the alphabet. So the CPT is always a 5-digit number. ICD has a letter. that it starts with. And then there's a bunch of numbers. So every letter is for like different parts of the body or like different sections of disease, like not necessarily parts of the body, but like infectious diseases are like of their own. So the BMI and the other codes that you might use, they're all in a specific section. Like you were talking about Z codes.
Yeah.
Every alphabetical, they're all alphanumeric. So it's like a letter and then a bunch of numbers and then point and then a bunch of numbers. And with both of them, with CPT and ICD-10, insurance companies expect you to use the one that is absolutely the most specific you can be. You have to get as specific as possible. Otherwise, they say you're billing incorrectly. CPT, that's easy, usually.
Yeah.
ICD is it's more challenging to really drill down because then it matters, like the decimal for your BMI even.
Yeah, because it's like Z68 something. So like 25 would be Z68.25, and that would be...
Should I go get a book? Should we get a prop? I'll be right back. Go for it.
But the Z68, like 25 is like the BMI of 25. But something with the ICD-10 codes to just keep in mind is that if you go to the insurance company website and pull the medical policy, or if you pull the policy on nutrition or nutrition counseling or medical nutrition therapy, how they would have it stated, the important thing to note is that there are specific ICD-10 codes that are listed under the CPT codes for 97802, 97803, 97804. So again, like this book that we're going to show you has a ton, it's really big and quite thick and thousands of pages and very tiny print. If
you're listening, I'm showing this book. It's ridiculous how big they are. This is ICD. It's the blue one. That's the biggest one. You're expected to flip through this thing and find your code.
And I was talking to another dietitian about the ICD-10, and they were asking like which ones they should write down. And I'm like, you can't write down all of them. There are common ones that we would use as dietitians.
Yeah, don't bother. It's 1,300 pages.
Yeah, and again, there's different codes in there that will never be underneath the umbrella of medical nutrition therapy, because again, if you're looking at the medical policy, they specify specific codes that are on there. So that's just something to keep in mind too.
CPTs, it's a smaller book and there's less stuff, but when I say smaller, it's like 1,000 pages instead of, it's 1,100 pages instead of like 1,300 or 1,400. But in my opinion, as someone who's like been doing this stuff, CPT is easier and ICD is the one that gets you in trouble.
Yeah. And just keep in mind, again, for codes like diabetes and renal disease and heart disease, and they're all like, there's diabetes with retinopathy and with, complication, there's all these different specifications as to making it more clear.
Real quick, ICD-10-CM is the one that you want. PCS is something else. There's ICD-PCS and ICD-CM. You want ICD-CM. We're currently on 10 for ICD-CM, and we're going to 11 soon, but it's not going to matter too much for you guys. It really won't.
Oh, okay.
There's only a few codes that are going to change them maybe, but yeah, don't worry about it. But ICD-10-CM is the one you want.
Okay. That's good to know. I didn't. So with the ICD-10 code, again, looking at the medical policy, but you want to make sure that what code you're using, again, if you have a physician referral to be able to actually use a certain code like diabetes, because you can't make a diagnosis, that you want to make sure that it's accurately representing what service you are providing and that it's matching to the client. Sometimes I hear in groups and see in groups people talking about like, what code can I use to get reimbursed? And you want to make sure that you're using the correct CPT code. And again, the ICD-10 that is accurately representing the service that you actually provided. So keep that in mind.
All right. Lots of stuff, lots of codes, fun things, lots of numbers, some letters involved. Amazing. So
here's more.
Yeah, there's more. I mean, so it's up to you to sort of figure out not just the code, but then sometimes there are place of service codes in addition to these. This is for CPT.
Yes.
So you'd also sometimes, you pretty much always need a place of service code. Yeah. And then sometimes there are modifiers.
Yes.
So that's sometimes modifier, but always place of service. So they're just like another, go ahead.
Yeah. So when you're filling out an insurance claim, one of the things that you'll be filling out is the place of service, and POS is what they actually use in the CMS 1500 form, which I didn't know. I had to Google that when I first started. And there's some common ones. So there's POS 11, which would be an office. There's POS 12, which is home. So I used to do home visits. And so I would use the POS 12 because I was doing in-home. Now, the POS there is O2 for telehealth. And this actually is recently updated, but not necessarily effective right now. The description changed. So it used to just be O2 telehealth. Now they updated it to be telehealth provided other than in patient's home. So the description change was effective January 1, 2022, and it's applicable for Medicare April 1, 2022. Now, some insurances have adopted this new language and some of them have not. They also added POS 10. So that was just recently added also in January. And this is telehealth provided in a patient's home. So the patient is home receiving telehealth for POS 10, and O2 would be they're at work, they're in their car for O2.
So there's a place of service code for not being at your house, O2, and there's a place of service code for being at your house, 10. And that relies like the client, where the client is. Either way, you're doing your medical nutrition therapy remotely for both of these codes.
Yeah. So, and this, again, some of the insurances that I'm networked with right now still use just O2 as a broad telehealth. And then I have one insurance company that has adopted the O2 and 10, so the updated language for O2 and then the language for POS 10. So
be careful if you Google POS and then something, because usually it's point of sales.
Yeah.
POS. All right, so that's place of service codes, and they would go along with the CPT code. Then there are modifiers that help you drill down further, more specific to what you're doing. That's the purpose of a modifier. Do you want to talk about which one to use?
Yeah, so the modifiers, you altered the service or the procedure in some way. So the common ones I use for telehealth are 95, which is synchronous telemedicine service that's real time. So it doesn't mean email. It means you are sitting actively with a client in real time. Now there's also GT modifiers, GQ and GZ, which are ones that I often see with Medicare. And we have a link that we will have in the resources part of the podcast that actually has a list of all of these different modifiers. And it's the link to Medicare's website because it's a very great description. So I use 95 the most frequently because, again, it's synchronous. So it's like I'm doing a video session, and a lot of insurances, if you don't have that 95 modifier, they will deny the claim, even if you use O2 for telehealth.
Because it's not as specific as it could be. They want you to be as specific as possible. Otherwise, you're wrong.
Yes. The GT, again, is something that I've often used with Medicare, and then GQ, which is asynchronous. Not one I typically use, but that's another one that you could see. And then GZ, which is another one that I've used, and GA modifiers are more so relating to Medicare that I've seen. But look at the medical policy for the insurance company because they specify which modifier to use for telehealth. And sometimes it's 95 or sometimes it's GT. Most of them are 95. So
just to clarify, synchronous refers to everything's happening in real time. You're on video, they're on video. You're talking to them, they're talking to you. What they're watching is happening live. Asynchronous refers to if you send them a video or an audio file, or if you are, I guess, emailing them, but it's not live interaction. That's the major distinction.
Yeah.
So what are we getting into next? Do you actually use those G codes? Those are super weird.
There was one I used, and I can't remember because I don't use it very often. It was for Medicare, and it was a G code because I knew it was a service that was going to be denied. And so it was deemed as not medically necessary. And so then that way it could be submitted to the secondary insurance for coverage, and it just goes quick right through Medicare. So there are instances where I've used a G code or that I bill Medicare and I know it's not going to be covered. The patient has what's called an advanced beneficiary notice on file, which is basically them saying, if they're accepting to pay, and they want you to bill Medicare still and whatnot, there's all these check boxes. There's a free one. If you Google advanced beneficiary notice, Medicare, there's a free template. You could download it and it has instructions on it. But that would be something you would want to be aware of and know what it is and use it if you're working with Medicare clients. But that would be another one. There's like another code for that if someone is going to pay out of pocket, but you're billing Medicare first. And so
I think it's important to note that in the world of like medical billing and coding, it's like you're a grain of sand on a beach in terms of the codes that you use and the services you render. It's ridiculous the breadth of services administered for like medical care, and all of them need to be billed and coded in a very specific way. So it can often be tough to work with insurance companies, but that's the battle that they're up against. They're trying to decipher exactly what's happening, and fraud is rampant in healthcare. So it can seem like you really have to fight insurance companies to get paid, but that's why they do this.
Yeah.
All right. Sorry, go ahead.
I was just going to say that if you're listening and you're probably like, my head is spinning, there's a lot of information to know. I use like the same codes and the same kinds of, like I always use 97802 and 97803. Like I'm using the same things over and over again. So it does get really easy as to knowing. And once you start working with insurance companies, you get to know what their policies are and things like that. So it does get easier. It could be a lot to just know what all this jargon is initially, but it does definitely get easier, especially with dietetics, because it's, we don't have the book that we showed is very big, but we're not using all of that. So
yeah, she doesn't need, we don't have these books because she needs them. We have them because I'm learning billing and coding. She doesn't use those books. There's only a few codes you need. So we kind of touched on how does someone know what CPT codes to use, because there's literally only 3 that you ever use.
Yeah.
I guess ICD is more complicated.
Yeah. And again, just remembering that you can't make a diagnosis. So if it's anything like heart disease or diabetes, or a client is coming to you and they're like, I have heart disease, and I was told that I can get unlimited visits with a dietitian, which usually means it's going to go under their medical policy of maybe they'll have a copay. And so if that's the case, you would need to get a physician referral or some kind of documentation from the physician with the specific ICD-10 code on it that you would use for billing. But you can't make the diagnosis, and you would have to have that referral on file to support the fact that you had a physician diagnosis, because we can't make diagnoses as dietitians. So
yeah, so you can't just wildly code for ICD like, oh, they have heart disease and they have pneumonia or whatever, and just code for that. Like, it's not, you can't just decide that.
Yeah, you can't look at labs and be like, oh, your A1C is high, you have type 2 diabetes. No, that's not out of your scope.
It could be true. It could be true, but scope of practice.
Yes.
You're not, you're kind of operating outside of yours. If you're diagnosing a patient with a disease that a doctor hasn't said, well, you have diabetes. That's not, you can't do that. It's a no-no in medicine, as it were.
You suspect it and you send them to their physician for more labs. And because usually that's the kind of stuff too, is that it would be separate occasions. They don't just diagnose based on one lab number. So, but that's under the care of a physician, and you could certainly work with them to get that documentation.
And that's what it comes down to a lot. If you need to, because there was a client you had where you're only covered so many appointments. Mm-hmm. And a doctor can diagnose or approve, and then some. It depends on the plan. I'm not going to get into it. Like, I don't know anybody's name I don't know anything about it necessarily, but I just know that you're able to have people see you still and be covered beyond their appointed a number of appointments. Like, usually it's 3 or 6 that people are covered for.
Yeah.
But you can go beyond that under certain circumstances.
Yep. So I've had clients where, and insurance companies where they have just like a blanket policy, like everyone gets 3 visits or 6 visits. But then beyond that, you would have to have some kind of medical diagnosis that warrants additional appointments. And so in that case, it would usually be some kind of a specific diagnosis code and like a referral from a physician to document the fact for this medical necessity. And then usually it's, sometimes there's a copay, sometimes not, depending on the insurance and that specific plan that they have. And then I have other instances where with the insurance, they don't necessarily have a BMI code that I could use. Maybe they're a healthy BMI. And so those Z codes just won't work. So off the bat, I need a diagnosis, and I need that, again, a referral. Even if their insurance doesn't require a referral, I can't make a diagnosis. So I have to obtain a referral still to be able to get that diagnosis code, or some kind of, again, medical documentation from the physician that has a specific code that I would use.
Well, so can we get more into that then? Because I guess we need to help people figure out what is covered, or like you need to know what is covered, and that's a battle too, because things can change, and all of a sudden it was covered and now it's not. So how do you actually figure out what's covered by someone's insurance?
So the best place to start, just in general, with each insurance company is looking at the medical policies. So when you look at the medical policy, it's going to have covered CPT codes, the ICD-10 codes, the POS specifications, and then modifiers. That's all usually on that specific medical policy. And then if you're doing telehealth, there's going to be a telehealth policy as well. So I would just start there first to just get a basic understanding of what the insurance as a whole would typically cover. Then you want to call and actually verify the patient's specific insurance benefits. And I would really suggest doing this initially. It takes time to do this, but when you first start out, you want to understand insurance, you want to understand these policies. And so if you were doing this initially, this will help you to get an understanding of that process and ask questions versus putting it off on your client, which you can certainly do, but I would start with that to be able to get an understanding yourself. Now, when you do call the insurance company to verify the benefits, you're going to need to have the client's member ID, so their subscriber information. You're going to need their date of birth, your NPI, and then the specific CPT code that you're going to use, and making sure that you always get a reference number for your call. So when you call, you can ask them, how many visits are allowed? Is a physician referral required? Is there a limitation on visits? Is there a copay for services? And you can ask all those questions. I just have like a template, and I can share that with anybody if you want to ever email me. I could share the template I use with you in terms of verifying benefits that just has all those prompts on it. But that's the information that you'd want to gather, because the insurance company will have specific information in their medical policy of what they cover, but you'll see a line in there about varies by member's plan, or check the specific policy. So you still want to verify insurance coverage for the particular client.
You don't have to do that for every client every time, do you?
No, I mean, most of the clients that I work with tend to use their, 6 visits or 3 visits, whatever are allotted. And so we don't necessarily, and it's the same kinds of plans that I'm seeing. So once I have an understanding of that specific plan, usually I'm not verifying for every single client. If it's a different plan or someone who's looking for extended visits or anything like that, that's what I'm always going to call to verify. But most of them have the same kinds of plans that I'm working with, so it's a little easier, and I kind of already have an understanding of it.
So some of your clients come from referrals from other healthcare facilities, or we're not really a facility, but other disciplines, like a doctor or something. So how do you accept referrals?
So there's a couple different ways. So actually, in using something like a pair portal, that is a platform that physicians use too, so not just dietitians, and it's anybody that would be under like independence. And so actually that's one place where I can accept referrals from somebody. The physician actually puts it in, and then I could search with the patient's information and find referrals in there for direct to me anyway. Another big thing, which is most of where I get my referrals, is through a Hipaa compliant fax. So I have an e-fax system. So the one I use is SR Fax. There's other ones out there. And it sends me an email. So you have to make sure that you're also using a Hipaa compliant email too, because if you're receiving faxes electronically, the database and the platform you're using, the platform you're using has to be Hipaa compliant. And then also where those faxes are going needs to be Hipaa compliant. So I get emails for these faxes, and then that's one way that I can get referrals. The other way is, and this is something that happens often, is the client will just get a referral. So they'll get it from their patient portal, or the doctor will write it out and give it to them, and then they'll send it to me. So I've had people mail them to me or fax them to me with the referral. So that's another way, but usually it's direct from the physician's office.
I always thought it was interesting that faxes are HIPAA compliant just by default, by the nature of the way the data is transferred.
Yeah.
They're like self-encrypted.
Yeah. It's, you have to make sure again that you get a HIPAA compliant one. And,
Well, if you receive it electronically.
If you're receiving it
if
electronically.
If you have a fax machine at a business or something,
it's
just HIPAA compliant, just straight up.
Yeah.
But yeah, obviously you as a dietitian working from a home office, you're probably not going to have a fax machine.
Yeah.
Maybe you do. I don't know, whatever. Yeah. Do you. But, if you're receiving them via email, then the email platform also has to be HIPAA compliant.
Yeah. And just something else to keep in mind. And I have this often happen. I'll call a physician's office and ask for a referral, and then they'll ask me to fax them a cover sheet or fax them the information that I want on the referral. And so sometimes that is the case too. So making sure I have a couple templates that I created of just, they're blank, and then I put in the patient information. I send that over with a cover sheet. And then I include my information and also what I'm requesting. And that's happened with medical records too, where again, sometimes I'll call and they'll just, what's your fax number? And they'll send it over to me. And then other times they ask me to fax them first, and then they'll fax it to me. So
I guess for a lot of people wouldn't guess that they'd have to be involved in fax and getting and sending and receiving faxes, because that's such an old technology, but we're still using it because of HIPAA mostly.
Yeah.
So what should a referral have on it? Or sorry, did I cut you off?
Well, I was just going to say that the other thing is that sometimes people will say like, my physician can put the referral in through the system, but I'm not using like a big healthcare system database. So like, what's Epic one?
Epic's the big one now, yeah.
So there's I'm not using that, so I can't access this referral. So just be mindful of that. As if a physician's or a doctor's office says, "Oh, we could just put in this system." It's like, what system are they referring to? Because I might not actually have access to that system, and then that's where the fax.
Well, you probably don't, and you probably need the fax. You probably don't have access to that system. How would you?
Exactly.
You don't use Epic.
No, and someone said it to me when I first started, and I was like, okay, and then I was like, where's it going to go? Like, I didn't think about it.
Ask for it directly. Say, I need it directly. Can you send it to me directly? Fax it to me directly. Don't let them put it into a system that they assume you have access to. Yeah,
because it was, private practice, individual provider versus, work a lot with hospitals and big networks. So it made sense. It just was not something I was running into.
Yeah, but also like a lot of practices do use those. Mm-hmm. Like if it's a doctor's office or something where it's a big building and you got a bunch of doctors in it or whatever, they probably do use Epic, and they might be assuming on the phone with you that you're part of something like that and not just, in your living room or something.
Yeah, they don't know that.
So what do we talk about what a referral should have on it?
So usually it's gonna have a patient's name and date of birth, the referring physician and their NPI, and then whatever ICD-10 codes and the reason for referral. Now, I will say that some physicians don't write like the exact CPT code. They usually just say like nutrition counseling or like dietitian visit, and then usually the ICD-10 codes. Now, you probably don't know all the ICD-10 codes when they come in. So like I do this with most of the referrals that I get, that I'm like, what is this code? And then I type it in to Google or ICD10data.com or something.
It's ICD10 database.com. That's I'll link it.
But that's just whatever it is. So I know exactly what code I'm using. Cause sometimes I've gotten some weird ones where I'm like, I can't use this because this doesn't have anything to do with what I'm doing in an appointment. But that will be something just to keep in mind is, you want the patient's name, the date of birth. So you know that they're referring for a specific patient. It'll have the physician's name and their NPI, and then again, the ICD-10 codes and the reason for referral, which again, isn't always going to be the CPT. It would be dietitian or medical nutrition therapy, or I've just seen like nutrition. And so sometimes that's just what's on the referral. You can also create a template, by the way, too. And I think the Academy of Nutrition has a free template, if you remember, but you can just create a template, because sometimes if they ask you to send over what you're looking for, I just have like a fill-in sheet and I put in the patient's information and then where to send it to and what I'm requesting. And then that way, all they have to do is like have someone sign it and put the NPI and the ICD-10 codes. So it can just help speed the process along.
Codes all over the place. All right. So how do you bill for an appointment that wasn't exactly an hour? What a segue. How do you break down minutes? So
the easiest thing and what to look at is the Center for Medicare and Medicaid Services, so CMS, they use the 8-minute rule as like an algorithm. So it's basically for those 15-minute increments. So if you saw somebody for less than 8 minutes, it technically doesn't count. So you didn't have an appointment, so you can't bill for it. So at least 8 minutes for any kind of appointment. And so if you're billing, a unit would be like 8 minutes through 22 minutes. So if you met with someone for 21 minutes, you can only bill for 1 unit. If you met with someone for 23 minutes, then that would be considered 2 units, or and so like 23 minutes to 37 minutes. There is a chart. If you search 8-minute rule Medicare, there's a nice little chart so you can just see, and it's got the ranges. So it makes it really easy to navigate the minutes. But again, it's 15-minute increments. But if you met with someone for 17 minutes, you can only still bill for 1 unit because it's less than 23.
Beautiful. Minutes all over the place.
Time,
right? I'm like, come on. What amount should you be willing to bill? What amount should you be billing insurance? Like how much, what dollar amount, I guess? And do you bill only what they reimburse?
So you want to, before you even start billing insurance, figure out what your usual and customary rate is. So what you would charge per hour, because that's the amount that you want to charge every single insurance company for the service that you're providing. Your insurance company that you're in network with would only reimburse you based on your fee schedule, but you still want to be billing them your, again, usual and customary rate. So that's the terminology that's used. Again, you being in network, you are within network with them. So you are agreeing to this contractual allowance. So if, let's say you bill $200, they reimburse you $150. You are agreeing to those terms being an in-network provider. So you're not billing the client for that $50 fee that you're not getting, because again, you being in network, you're accepting those rates. So dietitians are considered fee for service providers. So we basically have a service and then we get reimbursed for it. But all insurance companies would have a list of fees for services that are rendered from any healthcare provider, not just dietitians, and your fee schedule, which you may or may not get during contracting. Sometimes they won't send it to you until after the fact, would list how much you would get reimbursed per unit, but you want to still consider what your rate is, and then that's what you bill the insurance company.
Yeah, you don't want to set your rate to what the insurance company pays, because your rate's supposed to be the same across all companies, and their reimbursement, their fee schedules vary.
Yes.
Your rate shouldn't. Mm-hmm. So you have to bill for your rate. Rates all over the place. All right, what happens if insurance doesn't pay for a claim? What can you do? Can you appeal it? Should you bill the client?
So first, you want to check the reason for the denial. If it's an error on your part, you can resubmit for what's called a corrected claim. And if you're using an online platform, which some people don't use and they mail in claims, it can save you a lot of time. If there's a lack of coverage, then it would say on the explanation of benefits, the EOB, that there's a patient responsibility. You make sure that you have a policy in place for billing. So making sure that you have the client be aware of if a service isn't going to be covered or may not be covered, so they don't end up with a bill and they're like, I didn't know this wasn't going to be covered. I wouldn't have met with you. And then you're trying to track down payment. And if it's not in your policies, then you're going to have a pretty hard time. If it's applied to the deductible, so if a client has to meet their, let's say, out-of-pocket max first, it would say that on there as to what the insurance company paid. And again, what is the patient responsibility? So again, you cannot bill the difference between what you've submitted and your contractual allowance, because this is considered balance billing and it could violate your contract.
So given that the ever-changing landscape of healthcare is always going to be difficult to navigate, how does Peraza Nutrition navigate the ever-changing landscape of healthcare? Yeah, I used it again. It's a beautiful sentence. I'm proud of myself. How does someone keep updated? These policies are ridiculous, frankly. I'll just say it. I don't care. It's insane what you have to. I don't envy you. Just throwing it out there. Insurance companies are a bear. They're tough to work with, but you keep up with them. Mm-hmm. How do you do it?
So the first is honestly subscribe to the provider newsletters, because it'll save you a lot of Googling and trying to find it on their website. So like every month from a couple different insurance companies, some of them are sent quarterly, but some of them are sent monthly. There are policy updates and policy newsletters. Now, when you click on the link that's in there, some of it has nothing to do with dietetics. So like the one I just opened for one of the insurance companies is all about medications and formulas, and that has nothing to do with me. So I just do a quick search Nothing related to nutrition, great, everything is as is. And then there's other instances where someone changes their policy regarding telehealth, and that does affect me. And so you want to make sure that you're keeping up to date to know that a notification has been sent out and when a policy goes into effect and how it will affect your business. So definitely sign up for the provider newsletters. If you haven't signed up for them just yet, the insurance companies do have a log of those newsletters and medical policy updates. So you want to be checking those. But there's two key things. It's the medical policy that you want to look at. And there's usually going to be one specific to medical nutrition therapy. And then the other part of it is the telehealth policy if you are providing telehealth.
Something just happened recently.
Oh, yes.
Do we want to talk about this?
So, yeah, because this is public information. It's not something.
And you sent me this outline like a month ago or whatever. And this just happened like yesterday.
Yeah. And I just added it to the outline when I resent it to you.
Oh, did you? Okay.
Yeah.
So this is something breaking news, folks. Yes. Who is it? Independence?
Independence. And actually, they're not the only ones that I found out. I think Aetna too. And I'm not in network, so I'm not as keen to all their policies, but they also have this. So to back up for a second, telehealth during the public health emergency and, COVID and all of that, a lot of insurance companies were waiving like cost sharing and all this stuff. And telehealth was covered that maybe wasn't originally covered. Now, we all thought telehealth was here to stay. Great. Everything's lovely. And some insurance companies are now planning to reimburse less. So like 85% of what you would normally get paid from your contractual allowance. So they're reimbursing less for a telehealth appointment because they find that they feel it is not the same as providing an office visit, which I very much disagree with, especially for nutrition counseling.
It's unique to medical nutrition therapy.
Yes.
In that you can deliver the same quality of care via telehealth. Maybe that's true for other services, but it's certainly not true for medical nutrition therapy.
Yeah. So that has been something new. So if you work with Independence Blue Cross, check their telehealth policy and when their next update is out. So there's a notification that's out right now, and then it goes into effect June 1st, I believe is the date, 2022, of when they're going to start reimbursing at 85%. So that one is specific again to independence. I've heard and seen in some of the dietitian groups that I'm in that Aetna is doing the same, I think at 80%. So again, check the telehealth policy and check the provider notification center to see if there's any changes now or if there's changes in the future. Because I also ran into an issue where I was providing phone only sessions for an insurance company and they were covered. And then all of a sudden they decided they were not covered anymore. And it was something that
well, it wasn't all of a sudden they were not covered anymore. They were not covered. And they decided that so the policy changed July 1st. And then they started redacting payment from like May.
Yes. And they can do that. So they
apparently, I don't know how that's not illegal, but
I don't know either. But that was something that, and by retracting the payment, what they were doing was like I was supposed to be getting paid for future claims for other random members, and they were taking away that money. So instead of getting paid, let's just say $500, I was getting paid $200 because they were taking back money and clawing back that money. And from what I've read, I'm not as well versed in this part of it, but that they can do it for up to like 2 years or something. So I would just, check. And that's another reason why you want to make sure that you're billing appropriately, because even if you get paid for something, if you weren't billing it in the correct manner or using a code that you weren't supposed to be using, they could take the money back if they realize. So, and the ethics behind it too. So, but yeah.
Yeah, that's insane. Just to clarify what happened, she was doing telephone appointments from a policy in January, said they were good, that they were covered. She was getting paid for them. She kept doing this up through May, June, July 1, boom, new policy update. Now they're not covered, and they went back and retracted payment from appointments from clients in May and maybe April.
Yeah, May and April. They were pulled.
Yeah. And so that's what you can get into. That's the game with insurance companies.
Yeah, it was really
not Medicare, by the way, not the government one. Only the private insurance companies do this.
Yeah. Medicare is actually really cut and dry. It's nice because they're very clear as like, here's what we cover and here's what we don't. And so it's actually pretty easy to navigate Medicare. I feel like they're the ones that are the easiest sometimes to.
So weird that they're the ones that are easy to navigate, not the private ones, but capitalism anyway.
Yeah. And just by the way, if you are filling out a Medicare application, it's pretty lengthy and can be a little confusing. honestly, I think I've said this on another podcast, call them, because I've called them twice for the changes that I made or something I needed to fix on like my like provider section. If I updated an address and I needed to do something and I wasn't sure, they are super nice and they actually answer the phone. So you're not even on hold that long and they call you back and they give you direct lines. So that is really nice. So yeah.
So there's a bunch of laws surrounding all this stuff. Do you want to talk about like how you know which ones to follow and how to stay compliant?
Yeah. So there's a couple key things, especially if you're doing telehealth, to stay overall compliant. So the one is to look at your state website as to like what they actually specify for telehealth, who can provide telehealth, because that's in some of the laws written for certain states. So if you do have a licensure law anyway, you also want to be looking at that. You also want to review, the Academy of Nutrition has a lot of resources on telehealth, and they have office hours, which I didn't realize. They have weekly office hours that you can like drop in and ask questions about. So that's something else to take advantage of. And then the other thing is, again, obviously reviewing the insurance company website, because it will vary by insurance company as to what policies they have in place. And as much as, we have these state policies, you also want to be mindful of what the insurance company and what they decide they will reimburse for. And then the other thing is obviously things like Hipaa, that you would hopefully be doing anyway as a dietitian, because that's something that you should be doing, and being mindful of, keeping things safe and compliant in that way too.
Okay, so if someone's billing insurance, are there specific notes or formats that they need to follow when charting? Do you want to talk about some charting stuff?
Yeah, so there's no specific note you have to use, which is nice for private practice, but there is specific information that needs to be in a chart note. So the first is the start and end time for the appointment, so the exact time, 8:23 to 9:15, like the exact minutes need to be there. The total time spent, so you need the start and stop time plus the total time you spent. And then relevant things like Cpt codes, Icd codes, you need to have a signature or an e-signature. So if you're using an EMR, there's a spot where you would type your name in and like check a box that would apply an e-signature and the date and time of the appointment, and then lock the appointment. I personally use an expanded ADIME format, which is the assessment, diagnosis, intervention, monitoring, and evaluation, which is basically the nutrition care process. And it's just this format keeps me on target with all the information that I need to include in a note, and also provides documentation and justification for what I might be billing for too. So if an insurance company is looking for medical necessity, I have all of that information outlined. And again, I can look at the minutes and know exactly what I need to be billing to.
All right. That was a lot of stuff. Billing insurance is kind of a pain, but it is a way to have your services paid for that is not at the expense of the client. It's a good system overall. Some people just say, F it, and charge clients directly, and that's something you can do too. That's a whole nother thing.
Yeah.
How to bill people with that's
super
not
bills, all
insurance.
those things. Yeah.
Yeah, we can maybe talk about that another time, but I think that's going to do it. Anything else to wrap up?
Just the only thing is that, sometimes people will ask, if you're doing charting and anything, can a client actually get their chart? Like if they were like, I want a copy of my chart, legally, you do have to provide them with their chart. So as you're documenting, making sure that you are putting things in there in an objective way, and not putting in things that you wouldn't want the client to see, and things that are actually relevant to the appointment. Because again, at any point, a client could potentially request their chart. I will say most people I haven't had anyone ask for their chart. The only thing I've ever had people ask for is like goals or action items or like a resource to be sent. But most people are not asking for their chart.
So just to clarify, these charts, they are like medical documents. And as such, they are also legal documents.
Yes.
And they can be used in court and held against you in court. So it's important to keep in mind that you should be as professional as possible and make sure you have relevant information in there and not anything inappropriate or unprofessional, because it can be used against you, and it's a mess.
Yeah.
On that note.
On that note.
Well, you got to be careful with this stuff. There's a lot of legal ramifications for doing this wrong. Not a lot, but it can get you in trouble if you don't follow the rules. Fortunately, the rules are easy to follow. Yes. They're abundantly available, and most mistakes don't result in anything serious. They just result in maybe an insurance company not paying a claim or something.
Yeah.
It's not like you're going to get drug away to jail or the IRS is going to come after you. And,
Yeah.
it's not that big of a deal. It's easy enough to do. That's why we're here. We're trying to spread the word, make it easier. But there is a lot of stuff, so it's important to keep the varying factors in mind.
Yes.
All right, we're going to wrap it up here. Thanks for joining us for the My Dietitian Journey podcast. Until next time, stay saucy. We don't have one of these. We don't have anything to go out on.
I really thought you were going to say something else.
What do you think I was going to say?
Wherever you go, there you are.
That's true. You said it, not me. All right.
I did.
Thanks for being with us. See you next time.